Good morning, everybody. I am pleased to be back. I'm sorry I'm back late. Normally I do arrive for the entire conference, but I celebrated my third child's 18th birthday yesterday, and that was just not something I felt like I could miss. So I'm glad to be back. My name is Homme, and I am the Kakara. And over these few days, you'll probably get to know that that is appropriate designation for me. And I'm not sure, but my brother has decided that it's a good idea to have you listen to 3 Homme lectures in a row. I don't know if that's a great idea, but we'll try to keep things moving along and hopefully share information that is useful for you in your practice. This presentation is about triage, and it's about identifying who needs care first. It's an important part of any healthcare system. And I think it's important to understand what triage is, and it's derived from a French word that means to sort. And it's when we need to look at distributing limited resources across, in this case, a healthcare system or people, and figuring out how to put those individuals into groups based on need for immediate assessment or treatment. So I would say that breakfast is a limited resource, but we didn't triage that this morning. You guys triaged yourselves. If you wanted to make sure you got what you wanted, you got in line first. And if you weren't as picky, you didn't care, you knew that there was an unlimited amount of food, you just showed up whenever you wanted. The chairs in this room are also a limited resource, but you guys decided to position yourselves in different areas based on your own interests and needs and wants. We didn't place you in certain areas. So triage is something that doesn't always take place if there's a limited resource, but it does need to take place when that limited resource could have an impact on the health outcomes of the individuals that we are caring for. Oh, I'm going to go right direction here. And so it helps us to prioritize. It's a system that we use. And we use it in emergency departments, we use it in disaster settings, we use it in battlefields, and I'd also argue that we should use it in clinics, and we'll come back to that at the end of the presentation. So with triage, there's got to be a way to understand, like, are we doing it right? And so a common way to look at this is to say, how often are we under or overutilizing our categories? And so you can do a little bit of math, and in the next slide I'll show you how you do that to look at your triage system to see if it's accomplishing what you want. And no system is going to be perfect, so you set sort of parameters around these and say, we'd like to under triage only this amount of time, or we'd like to over triage this amount of time. And it really depends on how serious an under or an over triage might be. But as you can see here, under triage is not categorizing somebody in the group and at the higher level and then potentially deteriorating during the time that they're waiting. Over triage or over categorization is assigning a scarce resource to somebody who probably doesn't benefit from it. And this is just a way to calculate that, and this is a little bit more than just the 2x2 squares. This one has 3 different categories, and this is an example of a trauma triage model, where if we're going to look at over triage, we would say who got the highest level of the trauma triage categorization. And I'm going to go through some triage models so you get a sense of what these are. But saying we're going to bring all the resources to this individual as quickly as possible. And so they were designated at the highest level. But then, unfortunately in this case, or fortunately maybe for these individuals, many of them did not actually have a major trauma. And so the way you calculate this is you'd say how many people were triaged at the highest level but actually didn't need it. And that would be the A over C times 100. And over triage is something that a system will always have. But depending, again, as I mentioned before, on how serious under triage might be, you might balance things out by having a high level of over triage so as to not have too much under triage. And under triage is just the opposite side of that. How many people got a low level designation for activation for the trauma, got less quick care, got less resources brought to bear, but then ultimately were found to have something that was very critical or concerning, and that's under triage. And this is an area in a system where you look and you'd almost try to penalize this in a sense. Now, penalty is a really negative word, but you try to find ways to limit the number of under triage, but you also want to limit the amount of over triage, because remember, we're doing this because we have a scarce resource. And if we just triage everybody to the highest level, then it takes away that resource of the providers or services from other patients who may need them and benefit from them. So when we look, sorry, one slide behind here. Okay, so when we look at triage systems, vital signs are part of those, but they're not the entirety of them. And so they're important, but they're not necessarily always helpful in determining level of triage. So we want to have our triage system to be objective, and we want to include things like the chief complaint, although we know that patients can have varying types of chief complaints. And they still can be, if their chief complaint could be mild, they might say, I just feel a little off today, and they're actually septic, or they might say, I'm dying, and they're basically having maybe an anxiety attack. And we use that information as well as sometimes vital signs to categorize what level of triage they're going to have. The risk in not getting vital signs in any triage system is this. If you don't, there can be deterioration over time. The vital signs should be objective measures of the physiologic status of the patient. And so somebody who presents saying, I just don't feel right today, I'm a little off, and their heart rate is very high, and their blood pressure is very low, those vital signs sort of trump that very mild or innocuous sort of chief complaint that they've given you to say there's probably something more serious going on with this patient than just being a little off. So when we look at different triage scales, the South African triage scale was actually one of the earliest ones that was developed, and it looked at ways to expedite delivery and time of critical interventions for life-threatening conditions. They're seeing lots of really high acuity patients. They wanted to make sure that they were taking care of them as quickly as possible. And they also wanted to prioritize based on medical urgency. This was used to improve flow and satisfaction, not only flow and satisfaction for the department, but also satisfaction for patients. Although triage systems are not always going to result in increased patient satisfaction, because if you're triaged to a low level and you have to wait a long time, it's still very urgent for you. And they're not, and the people that are being triaged don't see the big picture of the department. They don't see that. So it's more to help to satisfy the system's needs and less at an individual level, except for those who are probably of the highest acuity that if we miss them, they could deteriorate. And then it's a system that's being able to be used by all levels. It's not just geared towards the highest level provider, the physician, or just geared towards the nursing, but it usually integrates all of them together in the process. So this is an example of African triage where it's a stepwise process. It's an algorithm to follow so that we can do it repeatedly over time and hopefully make it work well. And step one is just to look for something that's an emergency and a presenting complaint, and that's, if you see that, they're going to be the highest triage level. If you don't see that, then look for urgent or emergent types of things. And it goes through, and I'm not going to go through the details of all these triage systems just for the sake of time, but you're going to have these, you'll have these slides so you can go back and look at them, and there are manuals, you can look these things up online as well. But then you can kind of go through the stepwise process and ultimately assign a final priority level if it's not one of the highest levels, which you're going to detect right away. And then it gives you some action items to do. If they're a red or that, and often triage is done into colors or number systems. If they're a red, it means they need care immediately. Somebody who's in cardiac arrest doesn't have time for us to check their past medical history or figure out their insurance status or anything like that. They just need to go back and get emergency care. And then as you can see here, this system puts kind of a time limit on how quickly they should receive care. There's also a blue category here where it's kind of uncertain, and maybe the physician is going to weigh in, because most triage systems are actually employed by front-end staff, often nurses, using this information, but they are a collaborative process when there's uncertainty. And they are very busy slides. These end up being big posters that are usually on the walls of the front end of an emergency department, so people can review them over and over again. It gives them a flow diagram of how this system works, and it gives them examples of what might constitute a red or an orange. So over time, it's very overwhelming to try to develop a triage, or to implement a triage system well when you first engage it. But after time, it becomes kind of second nature. And so this is an example of the pediatric one here, where emergency conditions categorized by airway or circulation, coma, dehydration. It gives you some examples of that. It gives you some examples of what very urgent or urgent might be. And then there's also a triage early warning score, which is a TEWS up there under purple, on the purple. It's an early warning score based on vital signs. It gets back to that. Maybe the complaint is just fever, but the vital signs are telling you that this is more than just a fever. It also gives you some additional investigations that you might use in your triage system. Some triage systems will add in things like blood sugars or other diagnostic studies to help raise or lower a triage level, where other systems may not do that. In Canada, they focus on, in their triage here, the time to seeing a nurse and then the time to seeing a physician. And it's meant to be accomplished within the first 10 minutes of arrival. If you have a long queue of patients, that might be aspirational and not possible, but your system should hopefully be able to sort out the people that are entering it in a timely fashion, so as to then determine, again, those that need to be seen most quickly and those that can wait. So the Canadian ED triage and acuity scale looks at immediate time to nursing evaluation, immediate time to physician. And they give you it gives some visual cues on here as well to help kind of keep people on time, which is to say, about half an hour will be sufficient for a triage level 3 urgent. And there's still lots of examples of what that might be. And there's always, though, provider discretion in these things. Somebody might triage out at a lower acuity level, but because of some other factor, based on the experience of the individual who's doing the triage, they might bump them up, or they could triage at a high level and they might bump them down, because these are just guided. This is guidance for us. It's not a rigid rule system, but it does help organize things in a way, again, that we can go back and measure after the fact. How are we doing? And then we make changes, and I'll tell you a little bit about our trauma triage in a few slides and how we've adjusted that over time. In the United States, the emergency severity index is what's used most in emergency departments, and it's a 5-level triage algorithm. I am not a fan of this system. I think this system is inherently flawed. I wish we would change it. I think the Canadians and the Africans have figured it out better than we. But this system uses something that's kind of unique, not just to America, but to more resourced countries, which is how many resources are we going to use? How many tests is somebody going to need in order to figure out where we should put them? And the idea is that if they're going to need less tests, they go with a lower triage level. If they're going to need more tests, we're going to bump them up. Why? Because that takes time. And we're looking at how quickly we can move people through our systems as well. Not just their acuity, but how long is it going to take so I can empty out that room and put somebody else in it. But as you can see here, it doesn't try to designate any specific time to being seen. So you can get a triage level of a 3, which is an intermediate level, and be sitting for 8 or 10 hours if the wait room is very busy. But in the systems that we practice in, we often try to take care of some of that testing before a provider even sees you. Things to cut down time and how long you're going to be there if you're triaged at a level where testing is necessary. And this is just an example, and as I said before, I'm not going to go through this, but vital signs do play a role in here, but they don't play a role in the highest level of triage. And they only factor in when they're abnormal. If they're in a normal setting, if they're normal, they don't really factor into this. But in our emergency department, we are trying to figure out this idea of who's going to deteriorate in the emergency department while waiting. In our waiting room, as the length of stays have gotten longer and longer, we wanted to make sure that because we don't really factor normal vital signs into our triage system, what happens if those vital signs become abnormal while the patient is waiting after they've been triaged? So we have a system in place to bring them back and periodically recheck this vital sign, the vital signs. The level of acuity maybe isn't going to change based on their chief complaint or the estimated number of studies that they're going to need, but it could very well change based on deteriorating vital signs. And what's really neat with new technology is now we're going to be using a wearable biopatch that's going to continuously monitor people's vital signs in our emergency department waiting room and send it to a smart system that's going to alert the nursing staff that, hey, this person actually seems to be just getting worse sitting out there. Maybe they're just falling asleep and their heart rate is going down appropriately because of just relaxing, or maybe they're actually deteriorating. And so systems can be put in place to help with this. It's not you're a triage level 3 and you're that forever. It might be that you have to change that system. Triage can also be done in the pre-hospital setting to help determine if a place is the correct destination. Surgeons designated level 1, level 2, level 3, level 4 trauma centers. And in the pre-hospital setting, when the emergency response team is there, the EMS system is seeing a patient, they may say, I know that this facility is closer to me, but it's probably not the ideal place for this patient because they're meeting a higher level designation. So I will skip taking them there and I'll take them to a higher level designation status. And they've designated both adult and pediatric trauma centers. Some places are considered stroke centers or PCI intervention centers. And so patients, again, might be directed preferentially to those places if the resources of that place best meet their needs. We are becoming a geriatric center of excellence. And so I guess we're going to get more and more old people. We already see a lot of old people. Going to even come more because we're designating ourselves as a place that's really good at taking care of old people. There are also triage responses for teams. So we're going to call the trauma team down because it's a trauma activation, or the stroke team, or the STEMI team, or an imminent delivery team is going to come. And it's a team that's made up of obstetricians and neonatologists, or there's rapid response teams, and so or behavioral health emergencies. And so you put together teams, and then they're activated based on certain criteria, and that team will come together. So triage is more than just sorting our patients, but it's also sorting our resources for specific patients. This is a very busy slide, but this is our adult and our pediatric trauma criteria where I work. But I'll tell you that these are updated periodically and they change. So what gets may change over time based on calculations of over and under triage. And I can tell you that 2 iterations ago, something wasn't a red that became a red because of a few bad cases. And now after studying those same indications again, it's not going to be a red anymore. And so over time, we're figuring out that the system has changed as well, and so that the designation may not need to stay the same. Okay, so what about a busy clinic? I mean, these are clinics that we're seeing patients for really are kind of first come, first served, right? If you get there in line first, you should get seen first. Like when I go to Disney World, if I get in line first, I should be able to go on the ride first. Although they were not doing that anymore. There's all these ways I can pay to get in front of the line now. And so if you're affluent, you know that you're going to get to Disney World than if you're less affluent. And you have to pretty much be affluent to even go to Disney World anymore. It's gotten so expensive. But how do we decide which referral patients we're going to see first, and who makes that determination? Is it the scheduling person based on when they call in? Is it based on their insurance status? Is it based on their social status? Is it based on who they know? And then the question always comes up, well, what if a delay in evaluation could result in a treatable or curable condition progressing to a non-treatable or curable condition. Some clinics may be out 3 months, 6 months, and that's okay for our pediatric GI clinic to be out 6 months when it's a chronic problem that has already declared itself not to be life-threatening. But what if it's a new problem and it's a brain tumor that operated on or treated within a short period of time becomes something that is treatable or curable, but now transitions to something that is incurable. And because our system did not clearly identify that that patient will benefit from jumping ahead in the line of all the other patients, that their outcome has changed dramatically. And then we have to always ask the question, does ability to pay or insurance status play a role in deciding? And I don't know how much that, I know that that's changed over this time since I've come to Ghana, having more of a national healthcare system, insurance, but that doesn't cover everything. I certainly know that people from Canada who have a national healthcare system will bypass that system and come to the United States if they have funds, because their wait times are much longer for things than they are in the United States. And I certainly know that with the clinic that I work at, the Mayo Clinic, payer mix is one of the things that is discussed as part of a strategy for how our institution can remain financially viable. The payer mix is just a way of saying who's got better insurance and who doesn't. But one of the great things that the emergency department providers always get to wave our little flag and say, well, we take all comers regardless of insurance, yay for us, we're great. But this is part of a triage system, but it has to be something we carefully consider. And how do you guys feel this goes in Ghana in terms of insurance availability, social status? Does it play a role in triage for, yeah? And I'm not saying that there isn't some role for that. There's sometimes an opportunity to capitalize on the one group to help care for another group with less of fluid. So we've done that over a long period of time at the Mayo Clinic by making some rich people pay a lot of money for stuff so that we can use the excess of money that they pay to do charity care. So I'm not saying that that's entirely wrong, but when it is the only way you do things, or that's a way in which somebody with low acuity gets in front of somebody who needs to be seen first, that's an inappropriate type of situation. And that's on us to really police and measure. So that's what I've got for triage, just some things to give you to think about. And I know you do this all the time, you do this in your life as well. I also too am a procrastinator, so when I look at things that I need to do, I may have a list of things I need to do, and then one of the things I'll need to do that evening is go to bed. And so I make that list of all the stuff I need to do, and then I go to bed. And then the rest of the stuff will just have to take care of itself later. And that just happens to be my personality and how I triage things. And then I get up at 4 in the morning the next day and do all of them. So this is my email. If you have any questions, and like I said, you'll have a copy of these slides. And with that, I'm going to move on to my next presentation. Unless anybody has any questions, I should have paused for that. Any questions or comments while I pull up the next set of slides?